Everybody, please welcome. This is a series that we started doing that is now a bi-weekly series that is called the Eye Near Foundation Sight and Sound Bites. We are using this format, which is a Zoom webinar format, to present research and clinical innovations at the University of Pittsburgh Departments of Ophthalmology and Otolaryngology. I'm Lawton Snyder. I'm the CEO of the Eye Near Foundation. And the Eye Near Foundation's mission is to support research to advance care for vision, hearing, balance and voice disorders, as well as cancers of the head and neck, all the things that we take care of patients for at the Eye Near Institute at the University of Pittsburgh. We work closely with two of the world-renowned departments of ophthalmology and otolaryngology here at the University of Pittsburgh. And all the funds that we provide annually for research are only possible because of philanthropic donations. So I know there are many donors that are on the webinar today. Thank you very much for your support. Before I make the introduction for today's speakers, I need to go over a few housekeeping items. If you're familiar with Zoom, you know there's a chat feature, but for this webinar, we've actually disabled the chat feature, but we have enabled a question and answer functioning feature. So if you have questions at any time during the presentation, you can type them. You can click on the Q&A bubble at the bottom of your screen. You can type your question. We'll hold all questions until the end, but I will be reading the questions so that your question can be answered. So there's really no need for you to ever speak on the webinar. Obviously, we don't have your camera on, but we do have a raise your hand feature as well. There's a bubble with a little hand. If you click on the raise your hand feature, I'll see that you want to be unmuted to ask a question in person. That's also okay. We welcome that. It's just up to you whether you'd rather type or ask your question verbally. Tomorrow, you'll receive a survey email to provide us with feedback on today's webinar. And you'll also be added to our mailing list, email list for future webinars. You can certainly let us know if you're not interested, but I think that you will be. I'm going to go ahead and make some introductions here, because today we have I'm excited about today's program. This is a topic that's very close to me. I have a family member who deals with glaucoma, so I understand this very personally. But we have this topic, which is Horizons on Glaucoma Research, will be presented by Dr. Ian Connor and Dr. Ethan Rossi. Dr. Ian Connor is Assistant Professor of Ophthalmology, Glaucoma and Cataract Service, Chief of Ophthalmology for the UPMC Shadyside Hospital. He's a diplomat of the American Board of Ophthalmology. He's Associate Residency Program Director at the University of Pittsburgh School of Medicine. Dr. Ethan Rossi is an Assistant Professor of Ophthalmology at the University of Pittsburgh School of Medicine and Assistant Professor of Bioengineering at the Swanton School of Engineering, member of the McGowan Institute for Regenerative Medicine. He's the director of the Advanced Ophthalmic Imaging Lab. So again, I'm excited to see this presentation myself and participate, and look forward to the question and answers at the end. But please, Dr. Connor, let's get us started.
All right, thank you, Lonnie. So welcome everyone to this week's webinar. I hope that you find some informative and educational content here. I'm very pleased and honored to be asked to participate in this way. And even more happy to be able to share the stage with my colleague, Ethan Rossi. So you're going to hear more from Ethan here in just a bit, but I'll get us started. So to begin, this is a webinar about glaucoma, and I think probably it's safe to assume that folks who've tuned into this webinar have some interest or background knowledge about glaucoma, but I'm not going to assume too awful much. So you probably know that glaucoma is a disease of the eyes. If you don't know that, you may be on the wrong webinar, but glaucoma is, it turns out, a rather complex disease in which the optic nerve is damaged, and this leads to progressive, irreversible vision loss. So it's important to know about glaucoma that vision that is lost is generally not recoverable. So the stakes are pretty high to diagnose glaucoma early, to treat it in an appropriate time frame, to prevent people from losing their vision. Glaucoma, you may know, is the second leading cause of blindness worldwide. So it's a big problem. It is Of note, the only subspecialty within ophthalmology that is centered around a specific disease or a cluster of diseases. If you think about the other subspecialties in ophthalmology, they are generally sort of in reference to a part of the eye. There's corneal and external disease, there's vitreoretinal pathologies, but we're dealing with a lot of different diseases in those categories. In glaucoma, we're really just dealing with this one disease because it's such a huge burden for society. So most people who know a little bit about glaucoma understand that it has something to do with eye pressure. And indeed, eye pressure is important, but it's also critical to remember that glaucoma is a multifactorial disease that's defined by specific characteristics, such as a stereotypical optic nerve damage and visual field loss. So this happens in a relatively reproducible pattern in people with glaucoma. And that really, for as long as we've known about glaucoma, has been the hallmark of making the diagnosis. This is very characteristic pattern of optic nerve damage and visual field loss. We spoke about eye pressure a little bit already, but it's important to remember that a high eye pressure alone is not the cause of glaucoma. Eye pressure is, however, a significant risk factor. The way I like to explain this to my patients is that hypertension, systemic hypertension, is not the same thing as heart disease. But it is the most significant modifiable risk factor for heart disease in this country. In a similar way, eye pressure is not synonymous with glaucoma, but it is the most significant modifiable risk factor. And indeed, unlike in heart disease, where other factors can be modified, such as diabetic status, hypercholesterolemia, obesity, the so-called metabolic syndrome, in glaucoma, the only risk factor that can be modified is eye pressure. The others are beyond our control. So it's really important in managing glaucoma that we manage the eye pressure. And in the schematic, you can see a schematic of a healthy eye where fluid is produced by a structure called the ciliary body. The fluid circulates through the center of the pupil into the front chamber of the eye, where it's reabsorbed by a tissue called the trabecular meshwork into the drainage canal called Schlemm's canal. And in glaucoma in general, it's important to understand that the drainage system is not functioning well, or at least not functioning well enough to support the health of that eye. And that is one of the first problems that occurs in people with glaucoma. This results in increased pressure, not necessarily pressure above normal, but pressure that is too high for that eye. And we'll get into some of those nuances in a little bit when we talk about the types of research that are ongoing here in the department. So we all want to know if we're at risk for whatever disease we're talking about. Of course, there's a big infectious disease that we're all worried about our risk for right now in the world. Glaucoma is always lurking in the background for many of our patients. So it's important to understand what risk factors there are besides eye pressure. It's estimated that over 3 million Americans have glaucoma, but only half of them have been diagnosed. In the US, this means that more than 120,000 people are blind from glaucoma, and this accounts for approximately 10% of all cases of blindness in the US. We already stated that glaucoma is the second leading cause of blindness in the world. And after cataracts, glaucoma is the leading cause of blindness among African Americans. You'll see this a few times on this slide. Ethnicity is a risk factor. African Americans are more commonly affected by open-angle glaucomas in this country than Caucasians. So blindness is 6 to 8 times more common in African Americans than Caucasians, blindness from glaucoma. And overall, African Americans are approximately 15 times more likely to be visually impaired, not totally blind, but visually impaired from glaucoma. The most common form in this country is open-angle glaucoma of all flavors, and accounts for about 19% of all blindness among African Americans compared to 6% in Caucasians. But there are other high-risk groups in this country that predominantly means people over 60. So age is a non-modifiable risk factor. Family history, people who have a first-degree relative in particular are the ones I'm interested in. Mother, father, sister, brother with glaucoma is a significant risk factor. Diabetics and people who are severely nearsighted seem to be at a somewhat higher risk. So estimates, according to the Glaucoma Research Foundation, put the total number of suspected cases in the world at over 60 million. So that's quite a lot of folks who are affected or potentially infected, and that's why it is such an important disease. So as a matter of background, it's important to talk about how we treat glaucoma, and even more important to understand that as of now, May 13th, 2020, there's still no cure for glaucoma. There's a lot of great work being done here at UPMC as well as worldwide to try to change this fact, but for now that is the reality. So what do we do for glaucoma? We mainly modify the one modifiable risk factor, which is the intraocular pressure. It is true that most patients who have glaucoma, if diagnosed at an appropriate time before they have significant vision loss, will do well for their lifetime with what we term medical treatment. So this is pressure-lowering topical medications and laser treatment. The vast majority of people with glaucoma, if managed from an early stage, will never require incisional eye surgery. So early diagnosis and early treatment is really critical here. However, some patients with more advanced or aggressive disease do require glaucoma surgery. There is the traditional glaucoma surgeries, which are all variations on the theme of creating a new passage for fluid to escape the front chamber of the eye into a space outside of the eye. So the trabeculectomy, the tube shunt, or the two classic procedures that many people are familiar with, these bypass that site of resistance in the trabecular meshwork in the Schlemm's canal that is the predominant cause of intraocular pressure elevation. Completely bypass it, allowing the fluid to escape out of the eye in a very non-physiologic way into a safer space. These are the surgeries we've done for the longest. They have the longest track record. That means we know all of the many, if not all of the good things about these surgeries, as well as many, if not all of the bad things about these surgeries. There are risks for incisional surgery, including bleeding, infection, and even blindness. And we understand those risks reasonably well enough that we have gone out of our way to develop newer procedures over the last 10 to 20 years that have been termed microinvasive glaucoma surgery. And you see examples of some of these procedures here in the diagram: the Zangel stent, the Hydrus microstent, iStent, and iStent inject procedures, as well as a number of other procedures that we do. The point of these surgeries is to intervene surgically in eyes in patients who maybe don't have enough disease to warrant the risk associated with the bigger incisional surgeries, but certainly have disease that is progressive despite medical therapy. So these fit in the intermediate space in terms of treatment options. So that is the state of current glaucoma management. It's pretty remarkable that in 2020 we're still primarily treating this disease by lowering the pressure, and we believe that there has to be better ways to deal with this. So some of the unanswered questions that we have in managing glaucoma that we're trying to answer here at UPMC include, how can we make current treatments more effective and acceptable? Could we find a way to restore and recover the function of that natural drainage outflow system? Why do some eyes that have low pressure develop severe disease while other eyes with high pressure seem to be resistant to damage? What does the development of the optic nerve tell us about its function and vulnerability to damage? And how could we intervene to make susceptible eyes more resilient? And these are important questions that we're going to illustrate over the next handful of slides in a few minutes. We're going to illustrate how we are trying at the UPMC Eye Center with the support of the Eye and Ear Foundation to answer some of these questions for the better care of our patients now and in the future. So we have a number of glaucoma research labs here at UPMC. I'm going to introduce these in turn, so I don't have to go through the names right now, but you'll see all the names again over the next few slides. So Morgan Fedorchak runs the Ophthalmic Biomaterials lab. Morgan is a bioengineer by training, but she is working hard to develop or modify current treatments to become more effective and acceptable for patients. Using eye drops, for example, 2 to 3 times a day, multiple bottles, is a huge burden for our patients. We know that it's very challenging and that adherence to therapy is very, very difficult for people. So if we could have ways to better apply these therapeutics to people's eyes, we think that that would go a long way toward modifying the disease for probably the majority of our patients. So Morgan has developed a system by which she can load the ophthalmic therapeutics, the drops that our patients use, into a delivery system that utilizes a gel that becomes a solid when applied to the eye. That solid gel drop is of a composition very similar to a contact lens, which then can be hidden underneath the lower eyelid of the eye where it's not visible and not felt by the patient, and can elute therapeutic levels of drug into the eye over the course of a month or more. So it is very much true that the concept here is a once monthly eye drop for glaucoma. Furthermore, the gel can easily be removed from the eye as necessary. So this is a very exciting technology that Morgan has already patented for, or applied for a patent for. We're very excited, not only, however, for the utility of this technology in treating glaucoma, but in applying all sorts of other medications to the eye, including postoperative antibiotics, drugs that may be able to protect structures in the eye from glaucoma or other degenerative diseases, treatment for myopia in children, and most commonly dry eye syndrome. So many people suffer from the effects of dry eye syndrome. And if we could give the therapeutics for dry eye syndrome in a drop that's only applied once a month or less, I think we have a really incredible effect on treating these diseases. Yi-Chin Du is working on that second question I posed. Yi-Chin Du runs our stem cell biology and glaucoma laboratory. And Yi-Chin is working on the idea that we understand that the primary site of flow resistance is in the trabecular meshwork of the eye. We understand that the outflow capacity is what we term the ability for aqueous to leave the eye is diminished in patients with glaucoma. So Yi-Chin is working with a stem cell model to induce stem cell differentiation into trabecular meshwork cells. So this is really very exciting work, and in her animal study, she has shown not only a reduction of intraocular pressure, which is what we might hope would happen when we introduce new healthy cells into the drainage tissue, allowing for the aqueous to egress more readily, but rather incredibly, has also demonstrated a recovery of some of the visual function in these induced glaucoma model animals. So if you remember, I told you earlier that generally we understand that vision loss to glaucoma is lost, doesn't come back even after we treat. And yet in these animals, there is some evidence that that may not be entirely true, that some vision may have potential to be restored. So there's still a lot of work to do here, but it's a pretty incredible concept and paradigm shift from what we think we understand about glaucoma. So it's very exciting. Isam Aldiri runs our retinal epigenetics and genomics lab. It's important to understand that the optic nerve fibers are made up of retinal ganglion cells. The retinal ganglion cells, again, are the cells that begin in the retina, project to the brainstem and carry the visual information out of the eye, all of the visual information out of the eye for us. So he's really an expert at teasing out the development of retinal cells and retinal tissues, and is working hard to understand what the development of the optic nerve as represented by those retinal ganglion cells, can tell us about its function and vulnerability to damage. It's very difficult to understand how we could intervene to save these cells if we don't understand where they come from in the first place. So Isam is really doing the hard work here, basic science hard work, to understand how retinal ganglion cells develop that may help us identify genetic targets or otherwise for therapeutics to protect them from damage. Taka Kuwajima runs our optic nerve regeneration laboratory, and he's really working on this question of how we could intervene in a very practical way to make susceptible eyes more resilient. So this is a really fascinating story that Taka is chasing down, where a few reports had suggested, and he's trying to really drill down and understand how this could be and how we could exploit this, that statins can reduce glaucoma disease progression, stabilize the visual field, and even promote nerve fiber regeneration after injury. So statins are the drugs that many people take, and maybe many people on the webinar, to treat their cholesterol levels. It's a very common drug. I've heard more than one cardiologist comment that he would be in favor of putting statins in the water supply because of their effectiveness at decreasing cholesterol and damage from heart disease. So these are drugs that are very commonly used and have been available for a long time. And Taka is really working to try to understand how we could utilize these drugs, not just in their normal dosage and application, but maybe to use them in a very targeted way to treat optic nerve degeneration in glaucoma, as well as utilizing the knowledge gained from that set of exploration to develop new molecules and drugs that would be even more effective at promoting retinal ganglion cell survival with injury. So I think I've told you all I can tell you in the short amount of time about a number of the labs that we have here working on glaucoma research. We're very excited about all of this work, but I'm very fortunate to have here with us today Ethan Rossi. Ethan Rossi runs our Advanced Ophthalmic Imaging Lab, and the work he does is really pretty amazing in allowing us to better image in live patients down to the cellular level in the eye. So I don't want to take any of Ethan's thunder here. I know he has a lot to tell us. He's just a really great asset here. As an aside, before I shut up and let him speak for a few minutes, Ethan and his work is really dependent not only on support from the Eye Foundation and from funding agencies, but actually the direct support from volunteers within the Pittsburgh community. His imaging techniques are completely non-invasive, and I recruit patients from my own clinic to help develop the techniques that I think are really going to lead us to even earlier detection of disease and disease progression in our patients. So I'm really excited about the work Ethan is doing, and I support him by trying to find good candidates to help us make the technology better and better. So I'm going to stop sharing my screen now, Ethan, and that means you should be able to share yours.
Hello. Can you see my screen?
Yes.
Okay, great. Well, thank you so much for that wonderful introduction, Ian. And it's my pleasure to take a few minutes now just to speak about some of the work that we're doing in my laboratory. And thank you to Lonnie and the Eye Foundation for organizing this. This has been really great so far. I'm not going to take up too much more of your time, but I'm just going to briefly introduce one of the projects that we've been working on. Before I do that, I'm just going to briefly give an intro to my lab. So I direct the Advanced Ophthalmic Imaging Lab, and we are interested in developing and deploying high-resolution imaging technologies to better understand cellular changes in health and disease. And so we not only build new tools, including optical imaging systems in the lab, but we also deploy tools that have been developed elsewhere and modify them to do new things. Once we obtain these high resolution images, we also develop new image processing methods to generate quantitative data from the images. And ultimately, we would like to improve these advanced technologies so that we can enable clinical use and ultimately deploy them to evaluate the efficacy of novel treatments and vision restoration strategies. The technique I'm going to talk about today that we've been developing over the course of the past several years is something that we call multi-offset adaptive optics imaging. So adaptive optics is a technology that allows us to look inside the living eye and see clearly through the eye's optics, which normally would limit the resolution of a conventional imaging system. And we can do all types of imaging that can be done in the eye with adaptive optics. So it can be added to confocal imaging systems. It can be added to optical coherence tomography imaging systems. It's just a technology that can be really added onto any optical system to improve the optics so that we can see things that we normally would not be able to see. And this particular technique capitalizes on the fact that the retina is an optically thick structure that scatters light in multiple directions. When we are in a confocal imaging mode, which is illustrated here in the upper left corner of the slide, we are sensitive mostly to light that is more directionally backscattered. You could imagine that as light that's reflected back from the retina. But if we offset that aperture, we actually can select for light that has been multiply scattered through the tissue. And when we do that, we reduce this really strongly backscattered signal and detect light that comes from the more weakly scattering structures in the eye, including the retinal ganglion cells. So as Ian explained so well, the retinal ganglion cells are the cells that form the optic nerve. Their cell bodies reside in the retina, but they send these projections called their axons through the optic nerve to the next stage of visual processing in the brain. That's shown here in the cartoon, how they're arranged with these ganglion cells sitting on the surface of the retina and sending their projections here through the nerve fiber layer. Now, we are really interested in being able to see these cells because it's going to, we think, be able to allow us to detect earlier changes than we can currently in the clinic. Right now, we're limited by the resolution of our clinical imaging systems. One of those tools, as I mentioned before, is called OCT, and it's really revolutionized our ability to track the progressive loss of cells in the eye in glaucoma. But it's really limited in its resolution, and it really prevents us from being able to see small changes. And so we've been interested in improving the images of retinal ganglion cells so that we could really monitor and detect these really small cellular changes. We think with a tool like this, we could actually see the loss of individual cells. Right now with OCT, we are only sensitive to be able to detect losses of tens of thousands of cells. So we have 1 million retinal ganglion cells in each eye. And once you've lost a large enough proportion of them to be able to actually detect a significant thinning of the retina with OCT, you've already lost a lot of vision and you've already gotten far along the progression path. So we really think that new tools are needed for earlier detection and more precise monitoring. We think these types of tools are going to be really powerful for evaluating new treatments. So there's a number of limits in the technique as we had done it before. We validated it in non-human primates. We got these first in vivo images in humans using some detection patterns like this, but the process has been rather slow. There's been a lot of things that we've been doing to improve our imaging so that we can actually study these cells and quantify them in glaucoma. Another thing we'd really like to do is define the early changes that happen to the cells before the axons are lost, and we can detect this thinning. We think that we may actually be able to look in the eye and look at the retinal ganglion cells and understand whether or not their health has been impaired before the cells have been lost, which may, with new treatments, allow us to be able to rescue those cells before they're lost and before vision's impaired. So we've been developing new optical systems and new imaging protocols to really optimize the detection so that we can make this something we can routinely do in patients. One of those things has moved the technical side forward quite substantially that we've done is improve the optical setup. We do everything in one imaging wavelength now. I won't get into the details of why, but in the past we had used 2 wavelengths of light. Using a single wavelength has simplified things and made the optical system more complicated, but it made the imaging protocol much simpler. We're also moving away from doing this sequentially. Right now we have a detector that moves around and collects light from many different locations, and then we put those images together to be able to really enhance the contrast of those cells. It's slow when you have a physical camera moving around. So what we're actually doing now is building new all optical multi-aperture systems that will use a bundle of optical fibers that will actually relay that light to a number of detectors where we can acquire all the images simultaneously. That's going to make this a lot faster and get us closer to getting it to something that will be routinely deployed in the clinic. The other thing that we're really excited to do is to deploy these techniques more often in patients. And we're really excited to get back in the lab because we've got some really great results here from normal eyes. And we have a few early results from patients with glaucoma, but we're really interested in getting back and really beginning to push a lot of patients through with these new protocols and new setups. So that's all for me, and thank you so much for joining us today, and we'll be happy to answer any questions you might have.
Okay, thank you. Thank you to both of our presenters. I want to remind everybody again, as we said in the beginning, the way we're doing our questions. So you have a bubble at the bottom with it says Q&A. You can click on there. You can type your question. And then we also have a feature, which I'll be looking at from the participant screen. We have a feature that's called the hand raising feature. And if you see the little hand on the bottom of your screen as well, you can click on the hand, and we'll be paying attention here to know if when it's time to answer your question, we can unmute you. So please feel free. I see a few questions already we'll start getting to, but please feel free to ask. This is a golden opportunity because we have, the head of our glaucoma service here, but also, one of our clinical scientist experts as well. So first question is, what role does low pressure play in glaucoma? I guess this is for Dr. Connor to kind of reiterate.
Sure. So, I can muse on it a little bit. So it is true that about 40% of patients who have a diagnosis of glaucoma have a pressure that is never measured above normal. So it's always 20 or less, and sometimes it can even be very low. So how can this be? And we talked about this a little bit. We talked about the fact that some patients are exceptionally susceptible, that their optic nerves seem to lack the support, and that they are pressure sensitive even at very low pressures. So there are a lot of hypotheses about low tension glaucoma, but I think that really is the most resonant one, that in folks who are susceptible to low pressure glaucoma, the real problem is that their optic nerves are pressure sensitive at a much lower set point. Some of the other hypotheses about low tension glaucoma have to do with things like blood flow, and that's why we are looking at blood flow at the optic nerve head. It is definitely true that patients who have low blood pressure especially patients who really dip their blood pressure at night, seem to be the patients among our low tension glaucoma patients who are the most susceptible to damage. So, I think blood flow definitely plays a role. The fact is, at the optic nerve head, that is the only hole in the eye. The wall of the eye is made of tissue that is relatively rigid like leather, except for that one hole at the back. So all of the forces that come into play at that hole are exerting pressure on the optic nerve axons and can damage it. So I think I said a lot of words, which basically came around to we're still working out the answer to that question. Unfortunately, the only thing that we know definitively makes a difference, whether your pressure is high or low, is lowering the pressure more.
Very interesting. I know that that's something that is always confusing for people, is to understand the difference between, we all understand high pressure relates to incidence of glaucoma, but the low pressure glaucoma is something that is very confusing, and understanding how the other pressures on the optic nerve system play in that. I think that's obviously a big takeaway from today's discussion. Here's a question relates to, as you mentioned that, the African-American community is at higher risk for glaucoma. Is there anything that our department's doing that related to that to try to impact or help the African-American community learn more about glaucoma and testing?
Yes. So this is a really great question, and I think a really great opportunity. Sometimes you don't, even as glaring as they are, you don't see the blind spots in what you're doing, so to speak, and how you take care of your community until someone really brings it up. So although we don't have any specific outreach programs, I think that maybe that is an opportunity that we're missing. And as a department and as a foundation, maybe we could look for ways to better engage the African-American community here in Pittsburgh. In my own practice, which is primarily based at Ioneer in Oakland, I would say about 50% of my patients are African-American, despite the fact that the demographic in Pittsburgh, the percentage of citizens of Pittsburgh who are African-American is much lower than that. So the prevalence is real, and the issues for our African-American community are definitely very serious indeed. So I think that I appreciate that question, because it really points out that there's more that we could do, and we're going to work on that.
Great. Is there any imaging that is more accurate that will replace the standard visual field test?
So Jim, the issue here, I think that you're driving at, is one that everybody experiences. That everyone hates the visual field. Every patient hates taking the visual field test. I hate taking the visual field test when I've taken it out of some sense of need to commiserate. It is an imperfect test in a lot of ways. It is uncomfortable to take. Physically uncomfortable to take, psychologically uncomfortable, because as you're taking it, you have some fear that the results of this are going to either inform you that you've lost vision, or inform you that I'm going to suggest surgery or something like that. So people have looked for years into ways to maybe measure electrical impulses in the brain coming from passive visual input. The resolution of these techniques is very poor. It's good at detecting big losses of vision, but not the subtle losses of vision that we're looking for. So short of implanting electrodes into someone's brain to measure the impulses there, scalp-based measurements have never made it to be useful. As far as perimetry, that's what we call visual field testing, goes, I really think that the future is coming very quickly in that regards. And I think that some type of VR type headset is really the next step in visual field perimetry. There are a lot of advantages to that type of technology. A person could potentially even perform their visual fields from the comfort of their own home. If a VR headset was shipped to them, for use over the course of a few days and then ship back with the data. So there are some companies that are starting to develop those kinds of technologies. And I would say in the next 5 years, we'll have some of those commercially available for our patients to use, maybe even sooner, as the COVID crisis has really forced our hand to look at more and more ways to keep patients from having to come in to see us.
How long before the gel medication applicator can be used clinically?
I would say, my best guess, it's 5 to 10 years for regulatory reasons. The science is really good, and I feel 100% confident that it will be well tolerated by patients when it is available. There are practical issues to bringing something like that to market, and certainly there will be payer issues that will have to be worked out. But I think that is really a home run of a technology, and we're lucky to have developed it here at Pitt.
Another question here: what statins are potentially the best for glaucoma treatment?
Yeah, so the jury is completely out on that question. There have been a few papers written where statins are given directly into the tissue that have some hints, but we have no idea, what the answer to that question would be when patients take statins orally. The idea came from the realization in multi-factor analysis of glaucoma progression that patients who take statins, any statins, seem to have, in some of these studies, lower rates of progression. So I would say at this point, it's not quite a finding that's ready for prime time. It's a little bit maybe like the hydroxychloroquine story, that there is some suggestion that it's useful in clinical situations, but there are no big randomized controlled trials yet to really inform us as to how to prescribe. So if you're taking a statin for other reasons, I think it's good to take statins for other reasons as prescribed by cardiologists. But as glaucoma specialists, we're not ready to prescribe them yet because the data is still incomplete.
What is it about nearsightedness? This one is interesting to me too, because I have heard this before, but what is it about nearsightedness that causes glaucoma?
Right, so I'll say that we don't know for certain. It shows up again and again as a correlate in our analyses of patients with progressive glaucoma. My best guess, the best hypothesis for this, has to do with the structure of the eye. So nearsighted eyes are generally longer and slightly larger than other eyes, yet they started out the same size as everyone else's eyes. Those nearsighted eyes have thinner retinas, thinner sclera, so thinner tissue, and I suspect that the answer lies in a weaker support of the optic nerve as it exits the eye. So just more susceptibility to pressure-induced trauma.
Interesting. Is there a risk for people with previous eye injuries to be susceptible to early onset high pressure readings?
Yes, 100%. So previous eye trauma can damage structures in the eye, including that trabecular meshwork tissue that we discussed, the natural drainage tissue of the eye, particularly if you ever had an eye injury in which you lost vision for a period of time, more than a few minutes, because that suggests that there was serious trauma. So any patient who had an injury severe enough to lose their vision for more than a few minutes, and certainly if you had vision loss for more than a few hours or days, is at high risk of developing glaucoma in that eye in the future and should be monitored.
That is also interesting. Is there an upper age limit on when you still do more advanced treatments?
Well, the answer to that question is yes and no, because I have 90-year-olds who are in the physical condition of a 60-year-old, and I have 60-year-olds who are in the physical condition of a 90-year-old. So, I generally try not to subject very frail patients, very frail eyes, to significant amounts of surgery because their risk from complications is higher. Age is part of that equation, but it's not the only factor. So certainly my very healthy and robust nonagenarians, if they are losing vision and I can look them them in the eye and see that this person probably is going to live another 10 years or more, then there's no reason to let someone lose their vision without fighting to save it. If they are very frail, then that's a different story.
Well, this is one that also I'm interested in hearing the answer to. Can glaucoma result from diabetes?
No. So the two correlate in risk factor analyses. The most likely explanation for the correlation is that they are diseases that are most prevalent in people of the same demographics, right? The same age groups. Age is a significant risk factor, although people certainly in the U.S. are diagnosed with diabetes at younger and younger ages. One of the most significant risk factors for the development of diabetes, as well as glaucoma, is how many years you've been on the planet and going around the sun. So I think that the two track together because they occur in very similar demographics. There's an alternative explanation that has to do with simply the group that you're selecting. So patients with diabetes have an additional reason beyond the rest of us that have routine eye exams. So it may be that we pick up glaucoma at a higher prevalence in diabetics simply because they're having their eyes examined more frequently, so we can make the diagnosis in an earlier stage.
That makes sense. So do you see the current acceleration of vaccine development having a halo effect to speed up development or approval of novel therapies?
So I think I understand the question, and it never, I'll admit, occurred to me to think about it that way before. So yes, I do think that not just for glaucoma, but for a lot of therapies, that there will be a halo effect as regulations to bring drugs to market and therapies to market are relaxed in the wake of vaccine development and drug development to fight COVID. I do also think that it's likely that there will be at some point a backlash that occurs when some of those therapies have unexpected side effects when brought to the masses. So although I think that it's likely that there will be a halo effect, I also think that it won't last forever, and that we'll sort of loosen regulations for a time on drug and therapy development, and then end up tightening them up again as we see that it's not always founded.
Oh, that's also interesting. So there's two questions I kind of lump into one because they both, they really are for Dr. Rossi. So we should unmute Dr. Rossi here. What are the limitations to deploying the new imaging technology in the clinic, and how soon do you think it'll be available for patients, to start using it in clinic?
So there's a couple different types of limitations to consider. One is technical and the other is practical. From the technical standpoint, what we really would like to do is have a test that is robust, repeatable, fast, and something that will give us quantitative information that can be used to make patient care decisions. So we ultimately want to provide a tool that's useful to the clinician, something that's comfortable to the patient, and something that can be done quickly and interpreted quickly as well. So from a technical standpoint, we're working on all those challenges in turn to make it faster, and some of the things I mentioned about moving from sequential to simultaneous detections is part of that. Another piece will be developing the quantification tool. So we're going to be using advanced image processing and machine learning techniques to extract quantitative information about the cells. We're working on that currently. But the practical consideration to really get it something that be widely deployed in the clinic is really going to require an investment from a commercial partner. There are a couple companies that we have collaborated with in the past that have been leading the push to get the technology in the clinic. And my hope is that, this piece that we're developing for adaptive optics imaging might be something that could be an add-on to one of these new commercial systems that's coming along. So there's a really nice system coming from a company in France that we collaborate with, that will become available, we think, next year. And it's possible that a device like that would be one that this technology could be then added onto, because it would just be a module that could be, we envision, just sort of plugged into one of these new commercial systems. So on the order of years, we think, hopefully, before we could maybe have this as something that was incorporated into a clinical package. It's really going to depend on the overall utility, and really how effective it is for helping the physicians make decisions about patient care. And we don't have the answer to that. We think it's going to be really useful and really sensitive tool. But until we really have more data, it's hard to speculate.
Yeah, can I comment on that also? I think that from a clinical standpoint, it's not necessary that we have a detector that can image all of the retinal ganglion cells in an eye with a scan, or even over a large field like we do for traditional OCT. But to have it, because glaucoma is a disease where you lose retinal ganglion cells in a very stereotypical way, that we could use even very early on that technology to target the field of view of that kind of imaging system to just the population of cells that is most susceptible to loss. So I think, if we use the technology in that way, then the time needed for it to be applicable in the clinic is much shorter. We can get there, I think, much faster.
Yeah, that's absolutely right. We're going to have to certainly develop those protocols to know where to target, and we're working on that together now. And hopefully, the data that we get over the next several months, once we can get back into the lab, will help inform that.
Okay. We have one last question, but I will tell all the attendees that you're more than welcome to email us your questions. You have Craig Smith's email and your invitation. We can always get back to you any question that you may have, but we'll end with this one. Is there any nutritional supplements, or are there any nutritional supplements that could be helpful?
So I'll take that. So many listeners probably know that there's a vitamin called Preservision, or the AREDS2 vitamin, that we prescribe to patients who have age-related macular degeneration. That's based on two studies that were done consecutively: the AREDS age-related eye disease study, and then the AREDS2 study in patients who have dry macular degeneration. And the AREDS study showed that in patients who take the vitamin over a period of years, it decreases their likelihood of progression to more severe disease definitively. The study was repeated, and it showed the same result. So we are convinced in that population of patients that using the vitamins decreases their likelihood of progression to severe disease. Based on that, it would be nice to identify nutritional supplements that could do or have a similar effect for the treatment of other chronic eye diseases like glaucoma. Unfortunately, we do not have any large-scale clinical trial that has ever shown a nutritional supplement to be of benefit. All right, so that said, I have patients from time to time whose pressure we've lowered as much as possible. We've ruled out other diseases that can mimic glaucoma, and yet it appears that they're still progressing. And in those patients, there is limited data, small studies, anecdotes, that there are some nutritional supplements that could be a benefit. These include things like curcumin, which is turmeric powder, ginkgo, resveratrol, but none of these have a well-conducted large-scale clinical trial behind them. So I do not routinely recommend any of these supplements to my patients with glaucoma. The way that we manage glaucoma is to lower the pressure. On the occasion that I have a patient who is just desperate and we've lowered the pressure as much as we can, we'll try some of these other things with the understanding that some supplements that people take can have interactions with other medications that they may take and other conditions. So for that reason, I don't prescribe things unless we feel like we don't have much better options. Fortunately, those cases are very rare.
Yeah. That's great. Now, listen, everybody, thank you so much. All the attendees, as well as our panelists and participants and speakers today. this format is something that we've already found. This is the third presentation that we've done of these, and I have to say that it's been fun for me because, one, we get a chance to actually get to at least virtually see people and talk to people. It's what we like to do, but we also really like to discuss the research that goes on in the departments and share that with you. So we're going to continue to do this on a bi-weekly basis. Look for another invitation coming up shortly for the next presentation. We will go back and forth between the ophthalmology, otolaryngology, so you'll get eyes, ears, and other ENT related things on a rotating basis. Please respond to the survey you'll receive tomorrow. That helps us a lot. And please let us know if there's anything else, again, that you have a question about. But thank you. And thank you for your time, and enjoy the rest of the day here in Pittsburgh. For those of you who aren't in Pittsburgh, we have sunshine, and boy, are we excited about that. So thank you, everybody. You have a wonderful day.
Thanks, Lonnie. Thanks, Ethan.
Thank you.